All right. Hello, everyone. I am Aubrey Rhodes. I have the pleasure of serving as the Executive Director for the Lung Cancer Research Foundation. Our mission here at LCRF is to fund research for the prevention, diagnosis, treatment, and ultimately the cure of lung cancer. And research is smack dab in the middle of our name. And so, our focus is funding promising, innovative research. And we believe that the informed patient is empowered to make the most of research. And so our programs are really designed to bring the latest in research to you. So we're really excited about this particular program that we have today. Just a quick reminder, though, before we get started, we ask that everyone remain on mute. The chat will be open and you can type in questions right there, and we will try to answer everyone's questions as they come. If not, we will follow up afterward via email and make sure that your questions are answered. I will also share with you that captions are enabled both in English and in Spanish. You can turn those off in your Zoom settings. And I'd like to take a minute just to thank Regeneron and our other generous sponsors for making this program possible today. So today we're going to cover a wide range of topics from the recent Targeted Therapies on Lung Cancer meeting that took place last month in California. This is really a dynamic conference hosted by the International Association for the Study of Lung Cancer that summarizes data on relevant targets for new lung cancer therapies and kind of shares insights from preclinical and early clinical trials. Much like LCRF, the International Association for the Study of Lung Cancer is committed to improving lung cancer outcomes and really moving the needle scientifically for lung cancer patients. And actually, LCRF has partnered recently to fund research together with the IASLC. Just last year, we awarded a collaborative team science grant that was focused on curative approaches towards oncogenic-driven lung cancer. Despite the substantial progress that's been made in treatment for oncogenic-driven lung cancer, available treatments aren't yet curative, and resistance does invariably develop. And so, we need to have novel approaches to treating lung cancers and improving patient outcomes, ultimately with cure as the intention. And so this particular project is focused on furthering the development of novel therapies, including immunotherapeutic approaches for patients with oncogene-driven lung cancer. It's an excellent project and holds a lot of promise, and we're looking forward to sharing more progress with you as it unfolds. So now it's my pleasure to introduce to you our moderator for today's call, Dr. Isabel Preeshagul. Dr. Preeshagul is an assistant attending on the Thoracic Oncology Service for Memorial Sloan Kettering Cancer Center, and we are so grateful to have her here with us to really make the science easy for us to digest in lay language. So without further ado, I'll turn it over to you.
Thank you so much, Aubrey, and to the LCRF team for inviting us and getting us together for our first Together Separately in 2025. This is starting it off with a bang. We have so much to talk about. It's going to fly by this time. We have, an hour and a half to cover a lot. So we're going to stay as high level and impact changing as possible. Please feel free to put questions in the chat. We'll try to get to them as quickly as we can. But we try to stay away from, personal case reviews if possible, but always happy to, share my email and any questions that come in after can always be sent to Aubrey or Courtney or the LCRF team, and we can entertain them. So I do want to introduce the two incredible physicians that have signed on to join us today and educate us about everything TTLC 2025. The first is Dr. Benjamin Levy. Dr. Levy is a thoracic medical oncologist and the clinical director of medical oncology for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital. He is also an associate professor of oncology at Johns Hopkins University School of Medicine. Dr. Levy also joins me on LCRF's Patient Education and Engagement Committee, and this committee is focused on creating and cultivating education materials and resources for our patients and activities to engage them and make sure that they are as up to date with the latest breaking data as possible. So thank you, Dr. Levy. Welcome.
Thanks for having me.
Yes. And next we have Dr. Shirish Gadgeel. Dr. Gadgeel is the Vice Chief of Division of Hematology and Oncology and Associate Director of Patient Experience and Clinical Care at the Henry Ford Cancer Center Institute, Henry Ford Hospital in Detroit, Michigan. Dr. Gadgeel is also a member of LCRF's Scientific Advisory Committee. which is comprised of world-renowned thought leaders and scientists, physician scientists, who basically review and assess all grant proposals that are submitted to LCRF's research grant programs. So welcome. So happy to have you both here today.
Thank you very much. Really a pleasure to be here with both of you and with all the attendees.
Yes. So basically, as Aubrey had broken down so nicely, TTLC is really focused on talking about targeted therapy, latest breaking updates. So we're going to stay very high level, as I said, and we're going to first start with the targets. There are other avenues that are discussed at TTLC, and we'll get to them, but we're going to start with the targets first. The first target that we are going to start with is in the EGFR space. So there has been so much activity in this space that I am so excited to talk about, and bewildered and baffled with how we handle our patients that come to us in clinic. I'm going to ask both of you, I think we can start with you first, Suresh. Let's say you have a patient with, stage 4 non-small cell lung cancer harboring an EGFR exon 19 deletion. They're fit and they are treatment naive. How do you handle this visit? How do you coach your patient? How do you talk about the treatment options in this space?
So in a lot of ways, this has become complex, but also very exciting. 5, 6 years ago, we were all very excited thereabouts that we had a better drug than the previous TKIs in osimertinib, and that was the standard first-line care. But to some extent, the results of FLAURA trial that compared osimertinib to first-generation EGFR TKIs to some extent made it easy. We knew what we were going to do. There was a single option, and we treated them. However, what was also apparent is that as good as osimertinib was, and it's a great drug, that there it has its limitations. The median progression-free survival is about 17, 18 months. The overall survival in the FLAURA trial was 38 months, and we definitely needed to do better. And one approach was intensification of treatments. And so now we have 2 trials, the FLAURA-2 trial that evaluated combination of chemotherapy with osimertinib, and the Mariposa trial that evaluated the addition of amivantamab to lazertinib, another third-generation EGFR inhibitor, and each of those trials compared with the standard of osimertinib. I just want to say at a very broad level, right? When the results were first presented, I still felt osimertinib should be the choice in most patients. I will tell you that as I've seen the data and several updates now of both trials, I'm much more open to considering, and I would even say to the point that I am leaning more towards combination treatments than osimertinib. And the other thing that is clear is that we definitely now do not have a one-size-fits-all approach. That shared decision-making, which used to be a buzzword for a long time, has become extremely relevant, and one needs to tailor it. Very briefly, from the point of view of the case, how do I approach the patient? I really try to look at the tumor biological features, the clinical features, and then the patient's desires and the patient characteristics. And I think it's you do your best attempt to integrate all those factors and decide what is the best approach. And I think all 3 are reasonable approaches, and they need to be tailored as best as we can to the patient's individual clinical situation.
Very well said, and I agree. Might I add shared and informed decision making, as our dear friend Jill Feldman has taught me, is very important. Ben, what are your thoughts about these 3 great options? Also, clinical trial being an option, and how do you choose? Chemo OC, Ami Laser, OC alone trial.
Yeah, I think you choose carefully. I think Suresh has really done a nice job summarizing. We've got 3 competing strategies. Never has there been a time more important for shared and informed decision-making. I will tell you now that any patient that I see newly diagnosed EGFR mutant, who has EGFR mutant lung cancer, I generally give more than 60 minutes because the discussion is not just about osimertinib anymore. It's about potentially adding chemotherapy, and it's potentially looking at other combination factors like a combination strategies like amivantamab, lazertinib. You know, we're going to see data, are going to see it very soon about the numerical benefit of ami-laz over osimertinib in terms of outcomes. And I think the way that it's so important now to view this disease is as a journey. These are patients on a journey, and that journey is very long. And how can we give the most effective therapy and sequence therapies in the right way to, you know, provide the best chance for outcomes and survival, but also limit toxicities? What we need to remember about the chemo plus OC and the ami-laz combinations is that they are more toxic. The question is, can we get patients through this, and what does that quality look like? It's great to push the envelope on longevity, but if that comes at the cost of more time in the hospital or more time with doctors rather than their families, I think we've got to just make sure we're dotting the I's and crossing the T's when we're talking to patients about this. This answer is just a big hedge to say that, you know, every time I see a patient just like Shirish, I really talked about all the different options that are out there. What's important to you? What's important to your family? You know, these are so important now as we make decisions. I, like Suresh, have been historically using osimertinib. It's such a well-tolerated drug, but I'm starting to lean more towards these combinations. Hopefully we'll have data that comes out that shows how to mitigate some of these toxicities, specifically with the amivantamab lazertinib combination. Maybe this will help. Maybe it will be perceived as an over-medicalization of the patient. Don't know. I do think that just to end where you started is that this is very exciting. More options for patients, you know, very exciting for doctors, but perhaps, and of course, more important is for the patients.
Yeah, I agree. I love how you phrased it as a journey. I think we're going for the marathon, not the sprint. So we need something that's tolerable and doesn't impact quality of life in regards to the patient's standards. I know there was some data from FLORA 2 that perhaps there was a signal that patients that harbored EGFR exon 21 L858R insertions with brain metastases, maybe a little bit bulkier disease, may be a better candidate for chemo and OC compared to OC alone. Do you buy into that? Does that influence your decision making in clinic?
I'll start and I'll let Suresh, because Suresh mentioned this before. And, you know, it's yes and no. I think every patient's different, but sure, I will look at, as Suresh mentioned, biological factors, tumor burden, presence of brain mets, patient fitness, and really, yes, use that information. We've got some subset analysis to show that is a group of patients that may truly benefit from the addition of chemo, but there's such heterogeneity even within that group. But yeah, it will help me guide a discussion a little bit more with the patient. Maybe I would favor that regimen in particular scenarios where those clinical factors are a part of the patient journey. So I would say I think they're important. They make sense biologically why you may benefit from chemo. So I do look at that. But back to what Suresh said, it's an individualized sort of approach for me for each of these patients.
Yeah, I completely agree with what Ben said. I just want to highlight one thing. When we look at these clinical trial results, they were not necessarily designed specifically look at these subsets. We know these subsets with brain metastases, bulk of tumor, we know those patients don't do as well, or to some extent, the L858R mutation patients. That doesn't necessarily mean that combination is what is needed. We just know that these are not such good prognostic features. And therefore, we think that maybe that sort of not so good prognosis could be compensated by doing intensification of treatment. I just want to mention, we have patients that have joined us. If somebody is doing well on osimertinib for a period of time, their cancer has responded very well, they should just stay on osimertinib. with all this data coming up, I don't know that those patients necessarily need to switch to a combination. If you're doing well on osimertinib, that's perfectly fine to continue on it, and particularly if your cancer has responded. This is really, we are talking about newly diagnosed patients or recently diagnosed patients who may have just started on osimertinib, where we are looking at these combinations. And then the final thing is, when I look at combination, there is this perception that they may stay on the combination forever or for, a very, very long period of time. In the few patients I've treated with combination, I've sort of approached them, though that's not how it was studied in the clinical trials, as could this be sort of an induction treatment, that you try to do this combination treatment for a certain period of time, for a certain number of months, as long as the patient is tolerating it. And then when we reach a certain point, that maybe we could transition to a single agent treatment. That's not how the studies were done. But when you look at the median duration of treatment, particularly in FLAURA2 with pemetrexate maintenance, it was only continued for about 7-8 months, and we still saw an improvement in progression-free survival that reached somewhere in the median of 25 months, raising the possibility that it may not be necessary to continue this combination together forever to achieve the benefits observed in the trial. Even on the Mariposa study, half of the patients required dose interruptions, dose reductions, and the outcome was very similar between the patients who had dose reductions and dose interruptions as compared to patients who did not. Again, suggesting that combination treatment doesn't necessarily mean that they have to stay on that forever, and we can tailor it as we go along based on response, based on tolerability. And I think that that's important to note. So it is not combination or osimertinib. It could very well be combination for a certain length of time and then transitioning to single agent TKI.
Yeah, I just want to say this is, Suresh is highlighting what we do all the time, which is medicine as an art and not a science, and we individualize things. But I do want to just repeat one thing he said. If you're doing well on a drug, I get a lot of patients who come to me and say, hey, I heard about amivantamab lazertinib. I'm on osimertinib. I'm doing well, but I heard it's better, and I want it. And I think there's some level set that we have to have of saying, look, you're still deriving a real benefit from this drug. There's no reason to switch. And I think that's a really important point.
Yeah, I agree. And I love what you said, Suresh, about sort of phrasing it differently and calling it almost induction. I think patients get afraid that they think once they've committed to chemo every 3 weeks that you can't get off the train, or there's no end in sight unless they have a bad scan. So I love that. I think I'm going to steal that. So thank you for that. I know that there is actually some OS data hot off the press from Mariposa that just came out a couple hours ago, actually. And while we're anxiously awaiting the OS data for FLAURA2, does this push you a little bit more towards leaning towards Amy-Lazar in the frontline setting? Or are you still waiting, or you think the jury's still out?
I'll start. I think that we've had some experience with Amy-Laz under the umbrella of a clinical trial in the front line. And I will tell you that this combination is undoubtedly more toxic than Tagrisso. There's no doubt about it. And so the question that I always ask, is the juice worth the squeeze here? Is it? Do we want to give this, knowing that it's more toxic, even though we've seen now that the benefit in survival is more than a year? That's a compelling number. It really is. And so I do think, as Suresh and I were talking at the beginning here, I am starting to recalibrate who I want to give this to, but more importantly, how can we mitigate some of these toxicities? And how can we mitigate some of the over-medicalization that occurs with patients if you're giving them 17 different drugs to preempt the toxicity? So, and it's possible. It may be possible. So I look forward to seeing some of the data, some of these preemptive strategies to prevent toxicities, and I think we'll see that too soon. And I think it's worth trying. You can't sneeze at a year. I don't think, and Suresh has been around longer than I have. Sorry, Suresh, but it's have we ever seen a 12-month benefit in survival? I can't remember a time. So I think it's compelling, and it forces us to really have to think about what strategies are we going to integrate to try to make this journey, again, the journey, as seamless as possible.
I will just say that 6 months ago, I will be very frank, when I was thinking of combination, I was only thinking of FLAURA2. I was not thinking of amivantamab, lazertinib, mainly because, well, it got approved, I think, 4-5 months ago. But when it got approved, when I was thinking of combination, I was thinking of only FLAURA2, precisely because of Ben mentioned. I've seen toxicities when we have used that combination. But the survival data is definitely something that makes you say that we have to consider it. I will say on the chat, there was a mention of the subcutaneous amivantamab. I'm not sure when it is going to get approved. My impression is that it will get approved. It's a matter of time. And I think that is going to facilitate our ability to consider this combination. I think scheduling appointments, especially for that first infusion where it's over 2 days, there is the risk of infusion-related reactions. I think that becomes convenient. I'll tell you, at my health system, I work at a satellite office, but I arranged the first infusion in my main center because we don't have a hospital close to us in our satellite office. And I think just from a safety point of view, so those kind of factors come into play. And I think having subcutaneous amivantamab is going to make that as easy. And I think at this same meeting at ELCC, where the survival data is going to be presented, the data on management of skin toxicity is going to be presented. And I think that Ben is absolutely right. It probably means adding, 17 medications to the list. Probably is not 17, but we do that now also with chemotherapy, right? For nausea, we do give steroids for management of adverse effects. And so this may be a slightly more, but whenever we do combination treatments, we do have to incorporate medications to manage the side effects. And the final thing I will say is, yes, I'm old, Ben. Thank you for reminding me. But I think the advantage of getting old is I may have a slightly different perspective than Ben has. When I started back in 2000, the medians, we didn't even know about EGFR and ALK. And the median survival, not PFS, survival was 8 months. And so now when I see these data, I cannot tell you how excited I get. I think these are meaningful differences. And, these are the averages, right? There is a proportion of patients, yes, a minority of population that does even better than that, frankly, much better than that. I think that's the promise. So I feel, no, I'm absolutely impressed by the 12 months. And by the way, that's what is expected. And they did that calculation because the median survival was not reached in the combination arm. So we don't know what the exact median survival is. For all you know, it could be even more than 12 months, but that remains to be seen.
Well, I thank you for that insight. And I think we keep touching upon this toxicity. So just for those that are on the call that may be wondering, how do we offset this before the data comes out? Can you both tell me some of your practice about certain creams, antibiotics, what you do to sort of, I guess, proactively prepare a patient?
I haven't done so. So we had everything driven in our trial to that was sort of followed. And I think there's what we did in trial and what we're going to see from the data for the preemptive sort of management of toxicities. I do think that once this drug moves to subcutaneous, it's going to take care of a lot of things, specifically the infusion-related reactions. You're not going to get rid of the rash and the paronychia. It's still there, but certainly that's a big thing, these infusion-related reactions. I think that the doxycycline is going to be, pretty standard for these patients taking the antibiotic. I think some sort of triamcinolone cream or steroid cream is going to be helpful. I know in the trial, the preemptive trial, that they use clobetasol soaks for the fingernails and the hands, and that may be something. So those are the things that I'm starting to think about doing. I want to see the data in its full and when it's presented. And I don't know if this is the Skipper data or the Cocoon. I can't keep up with which one it is, Shirish.
Cocoon is the skin toxicity. Skipper is infusion reactions.
So right. So we'll have to see what they did and I don't know if it's just been presented as we're talking right now, but it will be interesting to see the measures that they've done. And I probably will try to adopt those measures if they're not too onerous. And I know it will be an antibiotic, it will be some sort of cream, and it will be some sort of soak. That's a lot to ask for the patient. But the question is, if you get patients that can do this routinely and you're extending their survival, and as Suresh mentioned, this is an average that we're seeing. I mean, the median hasn't even been reached. I think it's something that we have to start trying to do.
Yeah. Go ahead.
Sorry. I was going to say the other thing is, yes, there are situations. I mean, we did participate in Mariposa. I finally the patient had a significant scalp rash. I had to hold amivantamab. And I think that as we learn more about how many patients, what was the dose intensity of the drug in these patients, I think that we have to use all these measures, but despite these measures, we need to know that sometimes you have to just hold the drug or reduce the dose. And it's okay. I think what we will learn is, at least based on the data that is available, that it is okay that some patients have, despite all these measures, significant toxicity, and it is okay to hold the drug. We don't have to make the patient suffer, and you may still get the same extent of benefit. So dose interruptions, dose reductions is also a way of addressing toxicity.
Yeah, I think you're right. And I think it's going to be, not a one size fits all, and some patients are going to need more and some patients are going to need less, and each of us is going to have to sort of find our style. I know we've talked quite a bit about this, but there's just one other question that I think came up that Ben, you kind of highlighted, is about sequencing and sort of longevity. So I think the thing that comes to mind for me is, if, let's say, we start somebody on AMI laser, can we then give them OC, or would we be looking at a trial, or then would you move on to carbopamy-bev? How are you going to sequence?
Carefully. It's again medicine as an art and not a science. I think for those patients on our trial that we started on AMI LAS, typically those patients go on to get chemotherapy, sometimes with BEV, sometimes not. We've got an ADC, patritumab deruxtecan, that's coming down the pike, specifically in the EGFR space. We have another ADC, datopotamab deruxtecan, which may be coming down the pike in the EGFR space. So I think the sequencing strategies are going to be important, but a lot of unanswered questions. On top of that, you've got other drugs that may be entering the continuum. A drug like savolitinib, which is a MET-directed therapy, that's a pill, that may be entering the patient's journey at some point. Other MET-directed therapies, you've got ivonescimab. Which is a PD-L1 VEGF bispecific that looks great out of China, just published. And we're running those trials in the US now. So it's a crowded space, and it's going to take some time to figure out what goes where.
Not much to add. The other thing is, we do take into account whether the patient has oligoprogression. I mean, those principles that were applicable when we were using osimertinib as frontline, is it oligoprogression? Do we make an effort to identify the mechanism of resistance? There's a question coming up nowadays because these ADCs appear to work irrespective of the mechanism of resistance is. But it is possible that as we better understand with these combination treatments, what are the mechanisms of resistance that emerge, that there may be, at least in certain patients, the ability to proceed with targeted therapy based on the understanding of mechanisms of resistance. So clearly, most patients are going to need systemic therapy. It could be ADCs, it could be chemotherapy, it could be other such drugs. But I think those principles that we used to use when we used osimertinib as frontline therapy in trying to assess whether it's oligoprogression and look at local treatments in managing oligoprogression and looking at potentially mechanisms of resistance to, at least in some patients, have the ability to use treatment based on that understanding is still important to consider.
Yeah, I definitely agree. And I know there's a sort of another topic I had wanted to talk about in regards to oligoprogression and how we handle that. And I think, as you touched upon, the gold standard being, sending a liquid biopsy at that time and maybe biopsying the site of progression to run next-gen testing to see if there's any known resistance mechanisms, whether that be a histologic transformation to squamous or small cell, God forbid, or if it's, MET amp or some other bypass pathway. I don't think that, that's wrong. And I still think we should try to do that. But I think, with all these other options, I think it makes it hard to delay things, to wait on next gen.
Absolutely. Absolutely.
So I do want to move on a little bit, unless anyone else has any other thoughts or questions in the EGFR space. I think we have so much to cover, and I want to make sure that, not everyone on this call has, unfortunately knows somebody or is dealing with, disease driven by EGFR. So I think let's move on to the HER2 space, if that's okay. So HER2, as we know, is another driver that is seen in, many other tumors, gastric, breast, you name it, many others. And it was recently discovered, maybe 5-10 years ago, to be active in patients with non-small cell lung cancer. And while we do know antibody drug conjugates have been very active in this space, it seems like small molecules are starting to make their way in as well, which is great, because we know antibody drug conjugates, while they are, wonderful, it's still chemo, right? And it's very challenging, and maybe these smaller molecules might be easier to tolerate, and it may or may not be more efficacious. So, Ben, I know you're the ADC guy. You know a lot about these, 300 plus antibody drug conjugates in development. Could you walk us through a little bit about, like what an antibody drug conjugate is,
Sure.
and this space? And then Suresh, I'd love to hear about your thoughts about zongertinib and the BEI drug.
Yeah, I mean, I call the antibody drug conjugates the new kids on the block for lung cancer. They're not so new anymore. I mean, trastuzumab deruxtecan, which is the only currently ADC approved in lung cancer, we've now had this approval for the last couple of years or a year and a half to use specifically in patients that have lung cancer that harbors a HER2 mutation or now has HER2 overexpression, which is a different pathway. It's very confusing. The bottom line is these drugs, the analogy is that they're sort of like heat-seeking missiles. They have a monoclonal antibody that is really trying to seek out, once it's infused, seek out a protein that is selectively expressed on a tumor, but not on the rest of the body. So it's sort of this selective delivery of the monoclonal antibody to the tumor. So in essence, it is sort of targeted therapy. Now, this monoclonal antibody generally has what we call warhead or a payload. This is just a fancy, unique way to say chemotherapy. So they have a chemotherapy moiety on it. And the whole idea, and it's linked by what's called a linker. So those are the three components. And it's in a simple world, which it's not, essentially you give this drug, the monoclonal antibody find its way to those cells that are selectively expressing that protein, which it targets, and then it releases the chemotherapy specifically at the level at the tumor and nowhere else. Now, we know that doesn't happen. We know it's way more complicated than that. But this drug, trastuzumab deruxtecan, or TDXD, has shown response rates commensurate with what we see with targeted therapy, north of 50, 60%, So it does, in essence, function like a targeted therapy in my mind. It's not a pill, it's an infusion. But we now know again that we have an approval for patients that have lung cancer harboring a HER2 mutation. That's around 5% of patients, maybe 2 to 5% of patients. But we also have what's called a pan-tumor approval, meaning it's approved for all solid tumor malignancies that have not the mutation, but have high levels of protein on the cell surface. And that's what we call overexpression. And that's measured differently. So we are now forced, Suresh and I and Iz are all forced not only to look for the mutation, but we now have to look at overexpression, which is a different test because we can use this drug in both of those scenarios. The drug works well. It's again, it's been the darling child of ADCs in lung cancer. It's the only child right now. But we will have more coming down the pike. As you mentioned, there's more than 300 ADCs in development, and they're getting more sophisticated in how they're used. It's not a perfect world. I'm happy to poke holes in all the ADC excitement, but I don't think we have time for that. Bottom line right now is this drug is approved for patients that have HER2 lung cancer that harbors a HER2 mutation. It's currently approved after chemotherapy, although we very much try to get it as first line. And we try to use it first. But the nice thing is we've got these wonderful tyrosine kinase inhibitors that I'm sure Suresh can walk us through that look really promising as well.
Sure, I'm going to be able to walk through. Yeah. Well, I just want to highlight before I get into the TKIs what Ben mentioned. I think this group understands this, but it is important for patients to recognize that whether your tumor is HER2 mutation positive or HER2 positive, in that there is presence of the HER2 protein on your cancer cells sufficiently high enough. So it just not presents, but it has to be of a certain degree that trastuzumab deruxtecan. So HER2 mutation patients may not have a high amount of HER2 protein expressed on their cancer. And so those are two different things. And trastuzumab deruxtecan originally was approved only for patients with HER2 mutation positive lung cancer. And then subsequently now, sort of in any cancer, if their tumor has a HER2 level of a certain amount present on the cancer cell, on the surface of the cancer cell, it is approved. So I just wanted to highlight that. But now going back to the HER2 mutation positive lung cancer patients, there was always interest in developing tyrosine kinase inhibitors, similar to what we have osimertinib in EGFR mutation positive lung cancers. There was a desire to have, if I may, osimertinib for the HER2 mutation positive patients. And there used to be a drug called mobocertinib that was approved, but unfortunately, so that was in exon 20. I apologize, I'm getting confused. So this is now HER2 mutation positive. And now we have two drugs in clinical development. Data was presented on both drugs at the World Lung Conference back in September in San Diego. And both drugs showed very promising activity, over 70% response rates, duration of responses exceeding about 15 months. And more interestingly, it showed CNS activity. Both drugs showed activity against CNS metastases. There was diarrhea with both drugs, and it remains to be seen. It seemed to be low grade, but diarrhea, even low grade, can impact patients' quality of life. And so we need to see in larger data sets as to whether these data holds up. But the data looks extremely promising. And in fact, based on these data sets, both drugs have received breakthrough designation by the FDA for HER2 mutation positive lung cancer patients. And both drugs are now being tested in the frontline setting against chemotherapy to see whether these drugs whether those drugs provide better benefit than what the current standard of care is, chemotherapy with or without immunotherapy. Similarly, with trastuzumab deruxtecan, there is a frontline study that is being conducted. So a lot of promise, but right now we need more data to really know what the true value of these drugs is in the management of these patients.
Thank you for that. And I agree. I'm excited about this space, and I'm looking forward to having just more options for our patients. How do you see TDM1 or adotrastuzumab in this space? Do we think it's just going to remain on the back burner since we know the data for TDXD is slightly better? Do you ever sequence them, or how do you see that coming into play?
Yeah, TDM1, the OG of ADCs and lung cancer, it was there for a little bit. It never got approved. Same monoclonal antibody as TDXD, a little bit different payload. If you look at the data, the response rate to this compound is pretty good in the patients that have HER2 mutations. And the drug is approved in breast cancer. There is a potential to use it off label because it is in our pharmacies, but just for breast cancer, it's just not something that I've done sequence patients on trastuzumab deruxtecan, then onto adotrastuzumab, which is just another ADC. It's unfortunate this drug didn't get approved. It just didn't go that path. It's not because the drug was not tolerated or it was toxic or didn't have meaningful responses. It ended up not moving forward. We have it in breast cancer. It's just not, I've heard of colleagues doing this. I don't normally do it. Use that drug as a sequencing strategy. I would say that TDXD is first, followed by chemotherapy would be second. But I don't think it's unreasonable to think about. It's just not something that I've done.
And what about, oh, go ahead.
No. I said, sorry, I couldn't add. I don't think I can add anything to what Ben said. Sorry.
No, that's fine. I guess, historically speaking, there's data that says that patients that harbor certain alterations should not be exposed to immunotherapy, predominantly patients with EGFR alterations and ALK fusions and some of the other RET and NTRK. But there are some drivers that we don't really shy away from immunotherapy, right? Like in the KRAS space and maybe MET exon 14. And HER2 seems to be one of those that kind of straddles the middle. Like some people are absolutely no, and other people are yes, and other people are yes, but I'm worried about pneumonitis if a patient got TDXD first. So what has been both of your practice in this space when it comes to sequencing? And do you involve immunotherapy at all?
What I can say is in the past when, and as Ben has highlighted, I'm old. So I used to treat HER2 mutation positive patients even before these options became available, even in clinical trials. And yes, when chemo pembro was approved, I have used it in patients partly because we didn't have good options. My suspicion is that immunotherapy efficacy is likely to be in these patients similar to what we see in EGFR. And so my enthusiasm to use them is somewhat limited. It was much more out of lack of a lot of options that made me use it. Now that we have more options, and as you mentioned with this concern of pneumonitis, and we don't have as much data, but there's some suggestion that maybe there is liver enzyme elevation if we use the TKIs after these immunotherapy agents, as we see with some of the other TKIs in the EGFR and ALK space. So one will need to be cautious about using immunotherapy and then subsequently using these TKIs if they get approved. So for those reasons, and as now we are actually just started a clinical trial with NVL-330, another HER2 TKI. And so with all these options becoming available, I'm much more, preferably I can enroll a patient on a clinical trial, but if I have a newly diagnosed HER2 mutation positive patient, I'm less likely to consider chemoimmunotherapy, and I'm much more likely to consider chemotherapy alone if I didn't have a clinical trial option.
Yeah, I don't have much to add. I think you make a good point is, I always have to tell patients there's targeted therapies and then there's immunotherapies, and they're very different. And immunotherapy generally doesn't work for those patients that we give targeted therapy to, minus maybe MET exon 14, KRAS, and BRAF. And then, yeah, the HER2 is just kind of all over the place. And I will tell you that I am in line with Shirish. I usually don't use immunotherapy, obviously for EGFR, ALK, ROS, and RET ever. I wouldn't say ever, but rarely. And for the HER2, I will say it's the same. I have had two patients, however, who were, and gets back to the individualized treatment and kind of looking at everything, who were, former heavy smokers with a high PD-L1. And that's a clinical and biological, characteristic that may portend better outcome with immunotherapy. So in those patients, I will consider, if I don't have TDXD upfront, I will consider using probably chemotherapy with immunotherapy, not just immunotherapy alone. But HER2 is this kind of wonky space where it probably is like the EGFR and the ALKs and the ROSs. They just don't respond well to immunotherapy. But I think every once in a while, just kind of looking at some of my patients, and I would say the same thing for EGFR exon 20, which is another gene, obviously, that sometimes if you have a high PD-L1 former smoker, maybe it makes sense. It's very confusing right now. I think there are times I'm messing up drug names. I'm trying to figure out the sequencing. There's so much data coming down right now that if you're not confused, something's wrong. But that's great, because that means there's a lot of options, and we're pushing the envelope in terms of outcomes for our patients.
I think very well said. And before we just move on from the HER2 space to talk about some of our other topics, Suresh, you had mentioned NVL 330 and clinical trials. And I know we're talking about, basically approvals and things that are offered to you right now, but clinical trials should always be at the forefront of your mind. And I think there's a big misnomer that clinical trials are left as last-ditch efforts, or, oh no, my doc's talking to me about a clinical trial, that's not good, things are going bad. And that's so not the case. So if your doctor's not talking to you about clinical trials, then something is wrong, right? So they should be asking you and offering you at all different stages. And, we try to put the patients that are most fit and onto trials, and patients that, we put patients on trial right up front to move that needle. The only reason TDXD got approved and that we're looking at zongertinib now and all these others is because of trial, right? We talk about FLAURA2, we talked about Mariposa, we talked about, the FLAURA data. Those are all trials that happened because someone went on a study and moved the needle. So advocate for yourself. If someone talks to you about a study, it's really a very good thing. So
Isabel,
try to shift that.
If I, and I know we need to go on to so many other topics, but just because of what you said, I couldn't resist saying this. I have a patient who I first met in June of 2021 with EGFR mutation positive, exon 19 deletion. But when she presented to the ER, she had multiple brain mets, but she had a pretty large cerebellar metastases. And she had to undergo surgical resection because the neurosurgeon was worried about, even brain herniation. So she subsequently did get radiation to that surgical cavity. And we saw her after the surgery and the radiation, and I offered her the Mariposa trial. And I can tell you that I was shocked that, this 53-year-old lady who had just undergone craniotomy, never smoker, was offered a trial, and she said, yeah, I will participate. And she did get amivantamab and lazertinib. And I have no idea how she would have done on osimertinib, which would have been the standard of care option. And she's now coming up to June of this year, will be 4 years since she got diagnosed. She's now on only single agent lazertinib. We stopped the amivantamab because of toxicity after about 8-9 months. And she's on single agent lazertinib. She's 4 years out, and there is no, virtually no evidence of disease. Again, I have no idea whether she would have been just done fine, but I will tell you, I just found it so amazing. And every time I still see her, I see her every month on this trial. It is so courageous of this patient who had, out of the blue, diagnosed with brain mets, underwent craniotomy, and then she's offered a trial and just, I don't know how I would have reacted if I was in the same position. But for this patient to demonstrate that courage. And I'm not just saying this example because with God's grace, she has done well up till now. But it is at that moment for her to sort of accept the trial was a huge feat of courage for me. And so, um, and yeah, so the reason to offer her the trial was not because I felt I had no options. It was because I felt that potentially, if she went on the trial, she had the potential of doing even better than standard of care. I didn't know it at that time, but it was offered an opportunity to be able to do that.
So well said. I mean, I don't have anything. I mean, when we talk about trials, I always say we're going to talk about a trial. Number one, there's no placebo. Number two, the trial that we have is probably going to be better than any sort of standard of care I can give you. That's a testament to the science, really. I mean, the fact that we can now have these trials that everyone gets the drug or guaranteed to get the drug, and that we have a fair amount of certainty that these drugs, based on preclinical data or even early phase data, look way more active than what we have been able to give historically with chemotherapy or other options.
Very, very true. And I think those immediate disclaimers when talking about a study is so important to say, because you are immediately see patients kind of like exhale a little bit, because that's always a concern and a very valid one. And one other thing that I always add is that, it's non-committal, right? It's committal, but it isn't, right? You do sign consent, but I think patients always fear that once they sign onto a study, they can't come off. There's no end, like they can't get off the train. And I tell them, like, it's not advisable, but like you can stop. And if it's not working for you and your lifestyle, then you just stop, and that's okay. And that's important. You're not going to hurt anyone's feelings. No one's going to be mad. Nothing's going to happen. So I think that's another thing that I think is a misnomer for going on study. I'll come off my soapbox about that, but I thought it was a good segue. So let's shift gears a little bit and let's talk about the KRAS space. So I know this space had been really, the underdog for quite some time until the two KRAS G12C inhibitors came about, adagrasib and sotorasib, with adagrasib really showing maybe to have better efficacy with penetrating into the blood-brain barrier. Unfortunately, these drugs are still not approved in the first-line setting. You still have to see chemotherapy first, chemo and immunotherapy, and then get these drugs in the second-line setting. But there's studies that are looking at giving these pills, in the front-line setting and trying to move that needle. What has been your experience with these drugs, and how do you handle patients with these alterations? And also, how do you handle patients that have non-G12C alterations?
I think, we, for better or for worse, KRAS G12C targeted therapies haven't shared in the same efficacy as the other targeted therapies. That doesn't mean they're not going to. It's just, as they are now, these first iteration KRAS drugs haven't performed as much as well as we would like them to. That doesn't mean they haven't performed. They have. I would say, we need to remember that KRAS as a mutation, not subtyping it, is quite a swath of lung cancer adenocarcinoma. More than 20% of patients with lung adenocarcinoma will have KRAS mutations. And we are fortunate and blessed to have subtyped them out and understood that we can subtype and wed certain subtypes to these targeted therapies. And of course, KRAS G12C is one of those. And the drugs are fortunately oral therapies, sotorasib and adagrasib, and they are approved as second line. We need to remember that KRAS, as we talked about before, is a mutation that has immunogenicity, meaning chemo and immunotherapy work really well for these patients, better than it does for EGFR and ALK. Sometimes it doesn't work for it doesn't work for all KRAS, but clearly KRAS mutations are more commonly associated with smoking, and we've seen the data that these patients that harbor them are sensitive to immunotherapy. Unfortunately, we know that when we give these immunotherapy and chemotherapy, There is disease progression many times, and that's where these drugs enter. My experience with these drugs has been that they haven't been at the same level as an experience like osimertinib or for EGFR or alectinib or lorlatinib for ALK. The response rates are a little more modest than what we see with some of the other drugs. Nevertheless, there is durability in some of my patients who get these drugs. We have to be mindful of rash. We have to be mindful of liver function abnormalities. We have to be mindful of fatigue. And I do have patients who go on these pills and do very, very well. Like other patients, though, I just don't know who's going to do well and who's not going to do well. I think this is just the beginning of the story. I think we're a little bit more advanced when it comes to some of these other targeted therapies in terms of the development of these drugs. I think we're still at the beta version of the KRAS G12C story. We're going to get better, which is good. And there are patients who still have durable responses. But for my KRAS G12C, yes, it will usually be a chemo IO or chemotherapy and immunotherapy first, followed by, if not on a clinical trial, an adagrasib or sotorasib. Both are, have reasonable toxicity profiles. You just have to be careful, watch them, monitor their labs. That's how I approach the KRAS G12C space for my patients with that genotype.
Yeah, this is a really, I feel, an exciting space. And I think that just to provide a little bit of a perspective, we know about KRAS mutation since actually the 80s. But it has been very challenging. It's difficult to go into the reasons why, but it has been extremely challenging to develop these direct KRAS inhibitors for a variety of reasons. And so now, after having known about it for 40 years, to have at least right now in KRAS G12C subtype of KRAS mutation positive lung cancers, direct G12C inhibitors is tremendously exciting. I think the 2 points I would like to add to what Ben mentioned is, one is, I view these drugs as what we saw with crizotinib and ALK and with, gefitinib and yes, the efficacy with gefitinib and erlotinib and EGFR and crizotinib and ALK was better than what we see with adagrasib to sotorasib, but those drugs didn't provide the benefit that we are seeing now with the current TKIs. And so the expectation is that this is just a starting point and we will get more potent direct inhibitors. In fact, at least the sort of single-arm divarasib trial suggests that the efficacy might be better. Now, there is a randomized trial that is going to be done. It remains to be seen whether divarasib efficacy turns out to be better than what we see with adagrasib and sotorasib. And so I think we are in sort of, as Ben said, beta version of, we are in the first generation drugs, and possibly we'll have more potent drugs. But I think the second thing is, I do think the KRAS tumors are biologically more complex, if I may, than EGFR and ALK tumors. I don't want to say that one is easier to treat than others, but there is somewhat more biological complexity. And so I think that using a direct inhibitor against KRAS always may have certain limitations in terms of how efficacious it's going to be. As compared to, say, EGFR and ALK, where there is much, maybe less complex, so there's direct dependency on that EGFR or ALK pathway, whereas in these tumors, there may be other factors that the tumor could use even if you have inhibited KRAS for it to survive, grow, spread. And so we are already starting to use combination treatments in EGFR, and my suspicion is the real role of these G12C inhibitors, apart from developing more potent inhibitors, is going to be in combination, whether it's chemotherapy. There are some challenges with immunotherapy with certain drugs because of certain toxicities. But I do think that we are going to figure out sort of appropriate combinations, maybe other targeted treatments. I think that's where the true role of these direct inhibitors is going to be. And this needs to be studied. There's a lot of work to be done, but I think it's an amazing start. Though the benefit are somewhat more modest when you view it in the context of the EGFR and ALK drugs.
I think one other thing that has come across is combination therapy. Given the complexities of the RAS, RAF, MEK, ERK pathway, and how we're realizing if we just inhibit KRAS, we're missing all the other downstream, bypass mechanisms. So are you considering, or are you looking into, are you buying into the data of combination therapy? Are you thinking that it's more, combining sotorasib or adagrasib with chemo? Where do you think this space is going if we were to kind of guide our patients on the call?
Yeah, I think it's a great question. And I just wanted to jump in because we have a study that's looking at various combinations of Aloxo KRAS drug combination with chemotherapy and immunotherapy. I think both. I think, as Suresh mentioned, it makes a lot of scientific sense to look at these KRAS drugs in combination with immunotherapy because you're combining two drugs that biologically make sense for this type of tumor. The challenge has been the tox. The challenge has been with some of the compounds has been some toxicities. And I think we may be able to get around that in the future with some of these other compounds. And I do think that given the complexity of KRAS, as you mentioned, all the bypass mechanisms that are at play, a tumor that is historically very complex, just using a single agent may not be the way to go. And combining this with either chemo, combining it with chemo IO, combining it with just IO in the first line makes a lot of sense. We have a study looking at this. The drug, you just have to be mindful of the toxicities as it relates to, LFT abnormalities, pneumonitis, those types of things that can happen when you combine a KRAS drug with immunotherapy. So this is why I think the studies are being done. And there's a ton of studies out there. Very confusing to try to keep up with them all, but the work is being done. And my hope is the dust will settle on this within the next year or so in terms of combinations. Is it safe? Importantly, is it safe? And can we achieve better efficacy?
I will just add that we are definitely looking at combinations, but we are also looking at slightly different direct inhibitors. So again, just difficult to go into the details of this, but what adagrasib and sotorasib are what are called as off inhibitors. And we're going to have now what are called as on inhibitors. And again, maybe at another webinar, we can discuss what is on and off. It remains to be seen if these on inhibitors, KRAS G12C on inhibitors, are going to provide any better efficacy. But just another way of targeting KRAS. And then we have the pan-KRAS inhibitors, that is drugs that can inhibit multiple different sort of allelic forms of KRAS, whether G12V, G12C, G12D. We don't have drugs for KRAS beyond G12C inhibitors currently. And I think that what is interesting to Ben's point is many of these trials are not just evaluating them as single agents, but based on all the data we have generated, both in KRAS and other subtypes of lung cancer, they have built in sort of cohorts where patients will be treated with combination treatments, be it chemotherapy, be it with immunotherapy, or chemotherapy plus immunotherapy. So it's a recognition that as these new KRAS inhibitors are coming along, that they are being studied both as single agents, but also in combinations. Because I think the impression is that eventually that this is where the true value will be.
Great.
So I think we should move on from our KRAS space, which is ever evolving and so complex. We could spend the entire hour and a half talking about, as Suresh had said, on target and off target and all of the complexities here. But I think there's been some interesting comments in the chat, and I do want to get to talking about the patients that we treat with intention to cure in our last couple moments because we will be winding down at 4:55 a little bit early today. So I guess we can transition from talking about ALK to then talking about ALK in the early stage setting maybe, but there's some comments that about weight gain that happen with ALK TKIs. And I think we also see this with MET inhibitors as well, you know, and it's significant weight gain. And it can be very challenging to, you know, to lose the weight. So I think GLP-1 inhibitors have really entered the chat here in regards to helping us. We've become endocrinologists and we didn't even realize it. Thank goodness we took our medicine boards, but right, and recertified. But I guess the question is, how are you using GLP-1 analogs in your practice, if at all? Or are they not something that you typically go to?
That's a great question. And for the record, I did not recertify in internal medicine. So I have lagged behind. I am board certified in oncology and oncology only. So I've got several patients with this issue come up recently. I love this question because it's so relevant to what's been going on in my practice for the past maybe 4 or 5 months. I would say that the question hits the nail on the head. It's, you know, for at least for us, alectinib, the weight gain is bad, lorlatinib, it's worse. I've had to reach out to those who are board certified internal medicine, their internist, their primary care physician, and talk to them about GLP agonist. And 2 out of my 3 patients have gone on. One is a very young guy who gained over 50 pounds on lorlatinib. And is now, you know, back to his normal weight, being on a GLP-1, feels better. And the other is a lady in her 80s who gained 25 pounds. And so if you would have had this conversation with me 6 months ago, I'd have said I've never done that. But I have had some experience recently. You know, I think it's okay to do. I think it's compatible with the drug. I don't think it's going to limit efficacy, but I'm willing to be educated on this if others have different experience on this. Everything we know about the metabolic pathway and how it may contribute to carcinogenesis, and I mean, to me, it makes a lot of sense to do. Would I do it on everybody? No, but for those patients who have real bad weight gain, 30, 40 pounds, who can't shake it, whose quality of life's been impacted, I don't think it's a bad idea. But once again, we're in new territory. So I love having meetings like this with cross-fertilization of ideas, and also talk to others who may or may not do it. I don't know.
Yeah, I think a couple of things. I feel that we are recognizing weight gain as a side effect much more. So, you know, we know about lorlatinib. Ben mentioned about alectinib. We knew about alectinib, but probably didn't have a full grasp until recently about the extent of weight gain. And the thing about weight gain with alectinib is it can keep increasing the longer you stay on. So it's not like you gain weight in the first 4 months and sort of then stabilizes, but that weight gain can continue, at least in some patients. In fact, there's a very good article from a Dutch group that looked at all the alectinib trials and said that weight gain is underreported in those trials. I think that particularly in ALK patients, and I speculate whether it is true for other patients also, patients that we expect to do well for a long period of time. But particularly in ALK patients, I wonder whether we need to be proactive. That is, when we are starting them on ALK inhibitor, I think it would be important to sort of implement some sort of lifestyle modification, you know, exercise, nutrition, because I think prevention is far better. It is much more challenging to manage weight once the patient has already gained weight. Now, I'm not suggesting that we have any data that implementing lifestyle modifications right from the time of initiation of ALK inhibitors would necessarily make a difference in the extent of weight gain. But I do feel that as we are learning more and more about weight gain occurring in particularly ALK patients, that would be critical. I also want to mention, yes, I have not personally prescribed GLP-1 inhibitors when this issue has come up. Ben, again, older than you, so I didn't recertify in internal medicine as well. So I'm away from internal medicine even longer. So I do request them to discuss it with their internist. I just want to say in an extremely small number of patients in this paper, I think published in January of this year in JCO, there was a suggestion that the pharmacokinetics of alectinib was affected because it does impact gastric emptying. And whether that is the reason why alectinib pharmacokinetics are affected, we don't know. Whether that will be true with other drugs, we don't know. And even if it does that necessarily matter in terms of efficacy of ALK TKIs? I'm not sure. And is it sort of counterbalanced by the fact that the patient loses weight? And then the second thing is, should this be looked at as one step in a more comprehensive way of managing the weight? I mean, do we use this for a sort of a defined period of time? None of this is known, but I do feel this needs to be studied. And I'm certain that some studies will be initiated to understand this far better than what we know, but definitely considering it a lot more than what we used to in the past.
Yeah, and I'm so glad that you highlighted that that paper and also that the abstract that was sent in the chat. I thank you for that. I think we need to highlight the difference between decrease in bioavailability and decrease in efficacy, right? Because those are not the same thing at all. You know, there may be many different foods that you may eat that may transiently affect the bioavailability of the tyrosine kinase inhibitor that you're on. That is not going to necessarily correlate to the drug not working for you, or you having progression of disease, or you developing resistance. It's just a matter of there are certain times of the day where there's more bioavailability of the drug than less. So I agree this area needs to be studied, but I wouldn't necessarily at this point shy away from a discussion about a GLP-1 agonist in regards to helping with weight loss. I don't think that there's any clear data that it changes efficacy. Okay, great. So let's talk just a little bit about the early stage setting, right? Which was really, I think there was no approvals from like 2004 to 2020. And then all of a sudden we have Checkmate, we have Empower, we have all this stuff that came about in lots of different settings. And it's just so hard to kind of digest the data and understand how to handle this space for our patients, because right now we're seeing patients, majority of patients unfortunately are still stage 4, but I'm sure you both are seeing patients that you're getting referred to start something called induction therapy or neoadjuvant therapy, which means treatment before you go to the operating room, right? And this has been shown to improve, we get an idea of prehabitation, right? You're more fit getting treatment before surgery than you may be after. We can evaluate for major pathologic response, which means no viable tumor when the tumor comes out, versus, major is less than 10% and complete is no viable tumor at all, right? So there's lots of ways that we can evaluate how effective chemo is in these patients. So talk to me a little bit about how you handle a consult like this, and who do you offer sandwich therapy to?
Sandwich therapy, I love that. I think historically speaking, you're right, is patients that had early stage disease would see the surgeon would remove it and then send it to the oncologist to make a decision about whether more treatment is warranted or needed. What we've learned from these induction studies or neoadjuvant studies is that perhaps doing the chemotherapy with the immunotherapy first, followed by surgery, may be an alternative. We're not sure it's better than doing it afterwards. We don't have that study, but it looks more, at least to me, looks more promising in terms of the benefit there. And so I would say that this has changed our calculus on how patients are navigated through the system. If a patient sees a surgeon first with a mass that's localized, that's surgically operable, that surgeon will fortunately send them to me first to have a discussion about doing induction treatment. I think that can be hard for patients because patients just want it out. But we try, for the most part, to offer these patients, if they're the right fit, some sort of induction treatment with chemotherapy and immunotherapy. The question is, you take the patient to surgery and you remove it. do you offer more treatment on the back end? We just had this come up in our tumor board today, and it was a shocker, an argument between a surgeon and a medical oncologist and the radiation oncologist about who should get it and why. And so I think that for the most part, I would say if a patient gets chemotherapy, immunotherapy, then goes on to surgery, I tend to offer adjuvant or one more year of immunotherapy. There are scenarios that I've learned even this morning on our discussion about who this benefits after surgery, who it may not benefit. I think the question about whether a patient who has no viable tumor left over at the time of surgery, do they benefit or not with additional year of treatment? And that's a little bit, I think, up in the air. Although the data suggests maybe they do on a pooled analysis. So the high level here is that not only have we wrestled now with all these new therapies, but now we're talking about how to completely change the patient journey in the early stage setting, where we are offering them or trying to have that discussion with them about chemotherapy and immunotherapy, maybe first, followed by surgery, and then maybe after that, followed by more immunotherapy. So very, very interesting times.
First of all, I want to absolutely thank Isabel. You are doing a magnificent job responding to the chat questions. I don't know how you're doing multitasking so well. So really, really thank you for doing that. I don't know that I can add to what Ben said. I'm just going to highlight just a couple of things. One is the multidisciplinary nature. This is exceedingly critical that these decisions are made as a group. These are not decisions where, in stage 4 lung cancer, to a large degree, whether to give single agent osimertinib or combination, it's a decision to a large degree that you're making with the patient as a medical oncologist. But when it comes to how in early stage, whether you're going to do neoadjuvant chemoimmunotherapy or you're going to do surgery and then adjuvant treatment, or is there going to be any role for radiation in the early stage, it really is essential that this is done as a team and we come to a consensus about it. I will also say that having now treated some patients across the stages, sometimes patients get frustrated because they've been told they have lung cancer, and it takes a while for us to come with a plan in stage 4 because we need the molecular results and the PD-L1 results. And, that sometimes takes a little bit of time. In the early stage, we need the surgeon's opinion and the PFTs and, yes, and now NGS also in the early stage. And just as a note, again, we need to do this in an expedited fashion, and we can't take weeks and months to complete this. But I just want to mention to the patients on the webinar that sometimes it takes time, and I completely appreciate how frustrating it is. You've been told you have lung cancer, and every time I go in, the doctor wants to do another test. And when am I going to get started? And this cancer is growing in my body. And it has become very critical as these advances have occurred that we understand and get as much information as possible, both about the patient and the cancer, and make these the best decision for that particular patient rather than come with a cookie cutter approach. So I just wanted to highlight those 2 points, that this has become now a lot more multidisciplinary, where you need to partner with the other specialties. We always did that, but it's become a lot more critical. And then for the patients, that it does require a little more time than it used to in the past. And that is something that allows us to choose the best treatment for the patient.
Absolutely. And I thank you for that. Multi-D approach is so important. I do want to just comment briefly in the interest of time, and obviously we have a couple more minutes if questions come up. Oh, hold on. Let's address the questions. Someone submitted a question asking if someone has stage 1B or C and you start taking Tagrisso or osimertinib, I've been on it for a year with some break doses and changes, are you going to be resistant more quickly than taking it if you were diagnosed at a later stage?
I don't think so. I mean, I think that we know the data suggests that there's a higher cure rate or survival with being on Tagrisso, and for those patients who are 1B. So I don't think that the earlier stage getting it. I think I don't know where this question was going. I'm going to try to answer it the best I can, but these patients that we now have the data, the overall survival data showing that patients with 1B to 3A resected tumors live longer and are more likely to be cured with adjuvant Tagrisso than not getting adjuvant Tagrisso. So I never view it through the prism of, well, we're going to give it, which means we're just breeding resistance. We should just give it to you when the resistance occurs. I tend to just sway away from that conversation.
Yeah, completely agree.
I think there was some data that there is a greater benefit in the higher stage, but I agree. I would offer it.
Yeah, in Adura, the hazard ratio was better with stage 3 than stage 1B, but there was benefit in those patients as well.
Correct. While we wait for another chat question, there was one thing that came up. There was a subset analysis of Checkmate 77T that tried to kind of tease out, well, the patients that got chemotherapy and immunotherapy before they went to the OR and then had resection, then they went on to look at their pathology specimen after the surgery and tried to tease out, who really benefited by getting more immunotherapy. And so, correct me if I'm wrong, but I believe the data showed that it was patients that did not enjoy a complete pathologic response, and those that had a low PD-L1 were the ones that actually benefited most from getting more immunotherapy.
Yeah, this was the email that came out after our tumor board from my colleague Susie Scott, who was trying to prove her point, and I essentially showed that the PD-L1 zeros did derive a benefit with additional IO post-surgery. Even those patients that had a complete pathological response, it looks like maybe they got a little whiff of benefit, but it's not that much. And there was one more subset that I can't remember right now that was looked at that I can certainly pull up as we wait. But I think that the challenge here is that, as Suresh said, we're just diving into subsets and pooled analysis to try to come up with decision making for all of our patients, and that's sometimes very hard. A lot of this ends up, again, going back to when we started an hour and a half ago about shared decision making. There are clear times where you want to give adjuvant IO. The case we presented this morning was a patient who had a complete pathological response, but wanted everything possibly to be done and is willing to come in every 3 weeks and understands the risks. And I think that's an easy decision for the medical oncologist. It's if you want to dot the I's and cross the T's and wear belts and suspenders, and you're willing to deal with the side effects of wearing belt and suspenders, then that's okay. Because we're in the land of the unknown here a little bit. Clearly, there are times where you wouldn't want to give things because it's found to be a detriment. But it's interesting. I came from a meeting in New York last week where everyone was talking about giving IO, immunotherapy, after surgery when you had a complete pathological response. Everyone in that room was giving it. And then on the tumor board this morning, everyone's like, what are you talking about? No, don't give it. So you can just tell there's a lot of different opinions here about what to do.
One final thing I will say is that it was a little easy a few months ago when the only study that had shown survival advantage was Keynote 671 that used a sandwich approach. And so I said, well, I'm going to be simple. I'm not going to think a lot. That study shows survival advantage. Others as yet have not shown. It may be for a variety of different reasons, but I preferred the sandwich approach. Well, in the last, 3 months, we've now got a Checkmate 816 press release that says there's a survival advantage where it was only neoadjuvant treatment. So I just think we really need to know more information, and we are really choosing variety of different factors and deciding whether it should be just neoadjuvant or the sandwich approach. Great.
Well, we are just at time, and I I cannot thank you both enough for teaching me today. I'm scribbling down notes on my sheet of paper here to take to clinic so that I can data I need to review. And I thank everyone that joined us today and wrote such outstanding questions in the chat and made us look up and read papers. And I thank you so much for spending your afternoon with us. And I look forward to seeing you again.
Thank you
Thanks
very
for
much.
having. Great job moderating.
Yeah,
Thank you.
absolutely.
Take care.
Take care.